Hello, and welcome. And I'm Cassidy Avila with the Center for Optimizing Rural Health, also known as CORE. And I'm pleased to welcome you to this webinar on 2022 E&M coding updates. Thank you for spending the next hour with us. The knowledgeable Jackie King with ArchPro Coding will be discussing the E&M coding changes for clinics and rural hospitals. And I will introduce her in just a moment, but we are recording the webinar and we will be sharing a link to the recording as well as providing a copy of the slides with you in a follow-up email. We will also have time for Q&A at the end of the presentation, but do feel free to go ahead and drop your questions into the chat box during the presentation, and I will make sure that Ms. King addresses them during Q&A. So it is now my pleasure to introduce Ms. Jackie King, who has worked in the healthcare field now for over 30 years in both clinical and administrative positions at a small rural and critical access hospital, as well as physician practices. Sorry, Jackie, I just lost my place because I think we might have some feedback going on with some individuals who aren't muted. Let's see. In her prior role, Jackie worked in medical imaging technology, quality management, utilization analytics, health information management director, and as clinical informatics director. Ms. King received her Master of Science degree in Health Informatics from the University of Illinois in Chicago in 2012, and in 2016 joined the Illinois Critical Access Hospital Network as HIM Consultant in Compliance and Clinical Informatics Director for the Illinois Rural Community Care Organization, Accountable Care Organization. That is a mouthful. Yeah. Jackie joined ArchPro Coding in January 2019 and also serves as Director of Critical Access Hospital Education for that organization. Her primary duties include providing education, sharing resources, promoting efficiency and best practice, and improving healthcare services for small rural and critical access hospitals and their rural communities across the country. So Jackie, thank you so much for being with us. We always enjoy having you as a speaker, and I will hand it over to you now.
Thank you so much. Thank you. So yeah, within the last 2 weeks, my bio changed too. I have switched over to being a consultant role. I'm no longer employed at Illinois Critical Access Hospital Network. I have gone into my own LLC along with ArchPro Coding, which is pretty exciting for me. However, I am still consulting for ICANN, so I'm still sort of attached, but just in a different way. So I know there's some ICANN people on here. So I wanted to update everybody else. So it's a funny thing, as we were talking before we started, the 2022 E&M coding updates have been in effect since the beginning of the year, and actually since the beginning of 2021. And as we advertised this, CMS and AMA brought out the proposed and upcoming changes for 2023 for E&M coding, which is pretty exciting stuff, because what you're going to see here that the offices are benefiting from is going to switch over to your hospital. There's going to be other changes, but pay attention, hospital coders, professional fee coders. This is coming. I guess it just took them some time to get through it. So we do have the rest of 2022 to get through with what we're talking about today. But know that what we're going to talk about with the office and other outpatient is going to morph into what we're doing in the hospital, which is super exciting. It's hard to do it 2 different ways. So I'm excited. So what changed and what's the same? Let's talk about it. Again, this is my credentials, my email address. If you need to contact me, that's the best place to find me, jking@archprocoding.com. Thank you for that lovely bio, by the way. I need to update that. We're going to do the quick disclaimer about CPT. CPT is owned and written by the American Medical Association. All rights are reserved. So anything I am talking about today is with their permission to be using for educational purposes only. So on my agenda slide, my agenda is a little wrong. So the last HCC coding overview, we're not happening today. We already had that for CRH another day. So just ignore that last slide. We wouldn't have enough time to get all of this in 1 hour. So I did take that out. If you have questions, you can ask me. So E&M coding, what changed when? We'll talk about the old way, which is what we're doing in the hospitals now, hospital, nursing facility, and home, going to the home E&M. That still happens in our world until the end of this year. And then the office or other outpatient services, that's the new way that's already happening for those coders. And then we'll get into the meat a little bit more about using medical decision-making or time for E&M code selection, the new rules, and you'll get a lot out of this, hospital coders, and you'll get primed for when this happens at the 1st of January of 2023. So what changed and when? Only office, or what they call other outpatient E&M visit codes, changed. So the doctor visit code, CPT codes 99201 to 99215, if you're in the E&M section of the CPT manual, those are the ones they changed. And they did take effect January 1 of 2021. So they've been in effect 1.5 years. Observation, inpatient, or emergency nursing facility and home visits did not change. But again, stay tuned because they're coming and we're excited. So 2023, I'll be visiting you again, hopefully. Cassidy will have me come back and visit you guys. So the definition of E&M services in the hospital section, hospital, nursing facility, or home services, I'll probably just keep saying hospital because that's a lot of words. The code sets that you bill, they're organized into different categories. So obviously, the more complex the visit, the higher the level of code you're going to bill within that category. When you're billing these codes in these categories, the services have to meet the minimum definition of the code. So you have to read that documentation and make sure what you're billing, that code you're billing, is meeting those minimum requirements. 3 key components are required when you're doing that E&M level for emergency department or for the initial hospital or observation. And then remember that not for emergency department, but visits that predominantly involve counseling and coordinating care can be an exception. We can use time for those. So this is what we're looking at. I have 2 links, all the links that when you get your slides, all the links in the slides will be live. So we're going to quick link to the E&M documentation or E&M management, CMS E&M services guide, maybe. There we go. I think it popped on the different screen, but that's all right. We'll pull it over here. Okay, so this is an MLN. It is fairly recent, January of this year. Please use these MLN tools. CMS gives you these great informational guides to help you do your job, to help you teach your providers, to help you teach your staff, help you do your audits. So this is a great guide. This talks about what's going on now and the principles of really the 3 key components in the hospital section. So be aware of that and be using that. Those tools, they do a really good job. They keep them up to date. You can actually even keep them in your browser as a link. And when they update them, they usually don't break the link. So as you get a new version, it's going to be up there and you'll notice, oh, it was just updated last month. So that's highly recommended. And then the NGS E&M documentation and training tool is the other link. NGS is the MAC for Illinois, Wisconsin, Minnesota, I think. But just because it's your MAC in your region doesn't mean somebody might be sending claims to NGS from another area of the country too. This is an old tool, but what I want you to be aware of is you can absolutely use this tool for history, exam, and medical decision-making for your hospital encounters and your ER encounters. The office codes are wrong and they're old, but this is still out there as a link on the website. I use this, I have it laminated. I use a dry erase marker when I'm auditing E&Ms. I do it when I'm teaching new coders. It's just a really great tool to use. So that link is there. If you have a Mac, all of the Macs have some sort of documentation and training tool for E&M. Go out onto your Medicare Administrative Contractors website and see what you can find out there for tools. Some have interactive, fill in the blank, so you can practice and you can fill in the blank. It's kind of cool for your hospital. Okay. All right. So now we're in hospital. We're going to talk about the 3 key components that are required for you to meet that evaluation and management level: history, exam, and medical decision-making. If you read the guidelines, it'll talk all about this, the fact that you need to meet those 3 key components to meet the level for the initial. And then there are subsequent visits that only need 2 out of the 3. But there are also in the guidelines information about contributory components. What is the nature of the presenting problem? Were there counseling or coordination of care provided? And was there time, listed on the chart? So those are contributory. So what is that saying? Well, always remember when you're doing E&M coding, Medical necessity is going to be the overarching criteria for selecting the code, not the volume of documentation. I don't, not the exploding review of systems and the exploding exam and all of this. That's great. But if they came with a sliver in their finger and wanted to see if you could get it out and get a tetanus shot, I'm not seeing a level 5. So we have to keep that in mind. You have to pretend like you're talking to an auditor from CMS or your other payer and trying to substantiate what you're seeing in the note versus what the bill you're about to place out there with that CPT code. Medical necessity is overarching. That's kind of why they went where they went with this new medical decision-making versus time. And you'll see that when we get into the new way of doing things. So here we sit in the old way for hospital. This is a picture of what I showed you from that NGS documentation tool. I tried to blow it up a little bit. Your components are history. So your history of present illness is part of that. Location, duration, quantity. They want to tell me about what's going on with what is the chief complaint and expand on that and tell me how long it's been going on, what causes it to hurt more, and is there anything else going on with it that I need to know about? How bad does it hurt? All of that type of thing. How did it happen? That is your HPI. In an office setting, if you do in the old way, status of, well, actually, probably even in a clinic setting, status of 3 chronic conditions, even in a hospital, you could get a complete review or comprehensive history. Well, I'm talking too much. All right, review of systems. You have pertinent to the problem if only 1 system's reviewed. 2 to 9 is extended, and a complete is 10 or more systems or a few systems reviewed with the words all other negative. So watch for that. That can be exploding as well. So watch your documentation, make sure that every single time it always doesn't look exactly the same. Make sure that your EHR isn't misleading you with the documentation. Denies 10 times. Are we reviewing all of those systems every time? If you're not sure, you need to talk to your doctors. And then the other part of the history component is past family social history. What I want you to see here is when you are in the emergency department, you only require 2 out of 3 of this past family social to get a complete review or a complete past family social history. But when you are in a new patient or an initial hospital visit or an initial observation or an initial nursing facility visit, you have to have all 3 past family social documented to be able to get a complete, or it's going to knock you down to a detailed. Next slide, we'll talk about the exam. Generally in the hospital setting, we're hanging out in the 1995 guidelines. The 1997 guidelines came into effect to really help specialty docs that were maybe ear, nose, and throat, that were really only hanging out in the ears, nose, and the throat, to get more bullets in a very similar body area to allow them to get higher E&M levels. In the office, that's gone away. We need medical decision-making or time. We're getting there. But in the hospital setting, we're hanging out at the top. We're hanging out up here. What I want you to keep in mind is your Medicare administrative contractor may let you give and take organ systems for body areas. NGS, if I have extremities listed, I can use musculoskeletal. And if you give me abdomen with just bowel sounds, I can use GI. This is where you go back to your Medicare administrative contractor. Go to the FAQ section about E&M coding for hospital or observation and see what they're allowing. Know what they're going to give you for EPF or expanded problem focused versus detail. In NGS land, there's 2 to 7 or 2 to 7. So that's a little confusing, but the difference is this is checklisty type of documentation without any expanding notes on the findings, normal or abnormal. And if you get into the same 2 to 7, but you're expanding on more than checklist, then you've got a detailed exam. So that's the differentiator for NGS. Some do 4 and 4. You need to look at who your claims are going to. They're the folks that are going to be auditing your E&Ms, and those are the ones you need to be sure you're following. Everything else stays the same. The exam shifts a little bit. The thing that doesn't change is a body area versus an organ system generally. In the event you would get 8 or more organ systems only, you have a comprehensive exam. You can mix and match all the way through to get to 7, but in order to claim a comprehensive exam, we need to have 8 or more down here in the bottom of this tab. Okay. All right. Medical decision-making is that third key component. There are 3 pieces in the old way of medical decision-making. There are the number of issues going on or treatment options that we have for the issue or issues that are going on, the amount and complexity of data, amount or complexity and or. So those are the first two. And the third is the table of risk, the old table of risk. We take all three of these to determine the medical decision-making in the old way. So be sure, I've seen some coders, sorry, I gotta put the glasses on. I've seen coders get maybe they're new or they're rushing use prescription drug management and say, oh, I have a moderate medical decision-making. Well, no, you have a moderate table of risk. But in your other two pieces, do you have enough to substantiate that moderate between table 3A and table 3B? So there's three pieces of that. Be sure that you're using all three to decide your medical decision-making. Because you could have you could have an established problem that's stable and no testing, and then have a moderate risk, but you still have lower straightforward medical decision-making. That's the thing I want you to keep in mind on that. This is the initial nursing facility care E&M services. I kind of dropped these in so we could go through what they look like in the coding book versus what you just saw in that documentation and training tool. So initial nursing facility care would be your swing bed or somebody in a skilled nursing facility. Detailed or comprehensive history, detailed comprehensive exam, and the decision-making that is straightforward or low is what's going to tank you down to the lowest level. So when you get into the secondary, the middle level, you can't have a detailed, you must have a comprehensive history, a comprehensive exam, and moderate complexity of medical decision-making. So if I have comprehensive history and exam, but my medical decision-making is straightforward or low, I cannot pick this code. I have to go back to this lower code. You must have all three. That's what I want you to kind of know. And in this case, the differentiator between a 99305 and a 306, we've got that comprehensive history and exam. It's the medical decision-making. Now I have high medical decision-making. I can use a 99306. Otherwise, here I sit back in the 99305. Read your code descriptor. They will be your guides. I talk about a 3-stall garage when I'm talking initial facility visits, initial nursing facility, initial OBS or inpatient, and emergency department. There's a 3-stall garage for each of the levels. And unless all 3 cars are filling those garage stalls, you've got to keep moving your cars back till all 3 are in the same stall, and that's your level. I'm a visual person, and that helps. It's helped a lot of people. The light comes on when I talk about that. Here's subsequent. Now, here's what I want you to know about this. It's easier to get a higher level on a subsequent because you can see up in the descriptor 2 of these 3 key components. So I could have a detailed exam and a detailed interval history and straightforward medical decision-making, but because I'm in the subsequent, I can use a 99309. I can throw out at that low or straightforward medical decision-making and still bill my 99309 because I have 2. I have a detailed interval history and a detailed exam. So it's much easier, as it should be, because it's almost like an established patient visit in the clinic. You know them. You've already dealt with them on your first day or your second day or whatever. It is easier to reach that higher level, and they're giving you that leeway. These are just kind of blurry, but these are the home E&M services. So you'll see in this just a different view for you to see, depending on how you learn. 3 key components required for new, and these are the codes. And then as you're looking at the key components, you'll look and see what you might be seeing. And then contributory factors are something that you can take a look at too. So this is all in your E&M guidelines at the beginning of your book, of your CPT book. Okay. Then just the next slide is the well, if my slide will advance, the next one is your established 2 out of 3 key components. Again, you can mark it off and figure it out that way. However you need to do it and however you need to learn, there's 3 different ways you can look at it in a few minutes. So those are all the hospitals with the 3 key components. And a lot of the rest of this is going to start moving into the new office codes, but all of you hospital coders, keep in mind, pay close attention to this because this is coming for you. So you'll have a whole preview of things to come by watching what's coming on the next few slides. CPT deleted 99201, the lowest level of an initial office visit for a new patient, because they both have straightforward medical decision-making, and because the history and exam elements were the only two differentiators. Like we looked back at the nursing facility codes, they just got rid of 99201. So the new office visit codes start with a 99202. Okay, so that's kind of interesting. And there you go. Officer outpatient for evaluation and management of a new patient, which requires a, look at the wording, medically appropriate history and or exam. And or exam. This is up to the physician to decide what's medically appropriate. That feels weird, but that's what's there. And then it's talk about medical decision-making. And then when using time, 15 to 29 minutes. It doesn't say usually the time spent is, it's very clear. If you get time from your provider of any number between 15 and 29, you have a 99202. So much easier. This is coming. It will not be in the emergency department. We will not probably ever get to use time. It's a whole different ball game in the emergency department for E&M coding. For OBS and inpatient, which are going to merge, they will allow time. It's specific time it's going to happen. So wonderful. All right. So that's these codes. They just talk about 203 is low medical decision making. 204 is moderate. 205 is high. And then you've also got your times delineated out. Note that medically appropriate history and or exam is required. That's what the code descriptor is saying. If you're not sure how to make that as it's coming for next year, you need to have a conversation, HIM and your medical staff. What are we going to deem medically appropriate? Who gets to pick that? What do we got to look for? It scares people when they don't see a whole lot there. They're moving away from that because medical necessity is usually being driven by medical decision-making and or time. So that's exciting. This is the office visit E&M for the established. That's still there. 99212 is the beginning of that, 10 to 19 minutes. And there's your straightforward, and it moves up through the line. So these are the new codes in the office setting. Now, this is the way we used to code. This is just like a visual, the old way for a new patient office visit. We had a detailed exam and we had a detailed medical decision-making, but our history was only expanded problem focused because we didn't have 3 stars or 3 cars in the garage. We had a 99202. We start at the highest level and keep moving until all 3 cars are in the garage. Prior to now, and this is the old way that we do it now in the hospital, just with different E&M codes along the top. So this kind of can still connect with you. You would just put your different E&M codes along the top. Now, the new way, and the way that's coming for you hospital coders, medical decision or time. So I could have, it really doesn't matter, low medical decision-making, a detailed exam, expanded problem-focused history, but because I just get to pick my medical decision-making, I've got a 99203. I need to see something medically appropriate. I need to know what's going on a little bit. We can't just not have anything. So that's where you can start getting yourselves ready to talk to your physician staff, to talk to your HIM staff. What are we gonna deem medically appropriate? Let's get your ducks in a row, and that way you won't be struggling after the first of the year. The provider chooses whether he or she is going to document based on medical decision or total time for the office E&M, and that's coming for the hospital next year. Same 4 complexities, your straightforward, your low, moderate, and high. And then for a 2 out of 3 to get the highest scoring elements, 2 out of 3 is required. They did provide a lot of edits to this, and here is the MDM grid that came from CPT AMA. So it's very small. On the next page, I have the whole grid. It's kind of hard to read, but number and complexity of problems addressed is still there. Amount and or complexity of data also still there. And risk, your table of risk is still there. It's not necessarily the table, but your 3 pieces are still there. Okay, it's just, and when they look at the grid, they took things out like mild and vague things and redefined your data elements. It's so much easier to pick an E&M this way, my personal opinion. They've clarified a lot of things. So here is the whole, it's small. I'm sure you're seeing it small on your screen, but here are the three. So they're telling you, here's what your level is going to be, and that's going to map over to either your new or established patient doctor code, visit code. Here's your number and complexity. Here's your amount of data, and here's your risk. So when you're looking at these, it needs 2 out of 3 medical decision-making. That's how it was before. Just for your medical decision-making. Remember I showed you on that NGS, there were 3A, 3B, and 3C. And we picked 2 out of 3 and we selected. We're moving over. This is our 3A, 3B, 3C in the new way. All right, here we go. So when you're looking here, you see this little asterisk, each unique test order or document that contributes, it individually contributes to the 2 or 3. So each unique test, CBC, Chem Panel, UA, I have 3 tests, bam, just like that. I'm down here. I've got 3 unique tests, bam, I'm right there already at moderate. Just because I had 3 tests, now I need to know what's going on. Do they have 1 or more chronic illnesses with exacerbation? And did we do prescription drug management? If we have prescription drug management, and generally we're doing that in the hospital side, right? We're giving them medications and ordering at least 3 unique tests. We're at 4. So this will be coming. This will be coming soon, and it's going to make your life easier. This link in the slide, and I also have this at the end, brings you to this grid. So it's right on their webpage, and it tells you it was effective January 1. I imagine they're going to give us a new one, although I did not see it. I looked at the 42-page document, and I don't think they've given us a new grid yet. They may still follow this MDM and place the hospital codes down this first column on the left. Still coming soon. Yeah, it's just very new, but I want you to be aware of what's out there. Plus, I just love purple. It's my favorite color, so that makes me happy. All right, I see chats in the box. We'll be sure to get to your questions at the end. So this is another way of looking at the MDM. It's kind of clearer than that big graph. I'm just trying to bring it into focus. So here's your CPT, your E&M levels, and your type of issues, number and complexity, and the type of medical decision-making that's going to lay you into your codes. I'm just trying to give it to you different angles. When you're talking about, I'm going to expand a little bit more about that number and complexity of problems addressed. This middle column, self-limited or minor, it's going to run its course and it's not going to need any more treatment or follow-up. Acute, uncomplicated, short-term, not a big risk of death or bad outcomes, allergic rhinitis, seasonal allergic rhinitis, because it's grass or it's pollen. Now you've got chronic with exacerbation. It's acutely getting worse. It's COPD, they can't breathe, or it's diabetes that they're not controlling, or their asthma is poorly controlled. That would be a chronic, but it's exacerbated. Undiagnosed new, a new condition that could likely result in a high risk of morbidity, a breast lump, a wound that's not closing, a lesion that's unspecified, we don't know what's going on. And then chronic with severe exacerbation, severe progression, they can't breathe at all, their lungs are closing, or side effects of some treatment that's going on with a significant risk of morbidity. You may need to put these folks in the hospital. Okay, so if we're down here at chronic with severe, we're about to hospitalize these patients. And hospital coders, they're in the ER going up to the floor, or if we've just caught them up on the floor. So that's the chronic with severe exacerbation. So from 2021 later, new terms for medical decision-making determination. A problem now refers to, and here's a disease, condition, illness, injury, all of that, with or without a diagnosis being established at the time of the encounter. I'm not going to read the whole thing. Problem addressed or managed, it's going to refer to something that was evaluated or treated at the encounter. Remember that comorbidities or things that are going on that aren't specifically going on in the encounter are not to be considered unless they're addressed. So the problem must be addressed or managed. That doesn't mean we don't code the ICD-10 code for a coexisting or chronic condition and get our HCCs on the claim. That's ICD-10 coding. We don't leave it off of ICD-10 coding. But if we're not managing or addressing it today, evaluating or treating, we need to be careful. Test refers to imaging, lab, It's a single test. So a basic metabolic panel is one test, even though there might be 10 components, one test. If a test is ordered and reviewed as part of today's encounter, you only count it once. People are trying to double dip. Okay, so be careful with that. This is the middle column, amount and or complexity of data to be reviewed. I just kind of expanded it out for you. We don't have to beleaguer the point, but it's a little easier to read. So when I'm looking for limited, I have to have one of the following two. Did I review any old notes, or did I review some results of each unique test, or did I order each unique test? So if I ordered 2 tests, I'm good. If I reviewed results and ordered 1 test, I'm good. Or assessment requiring an independent historian could be a low. So someone besides patient. And then we get into moderate. It must meet at least one of the following 3 categories. Again, review the notes, review the tests, ordering assessment requiring an independent historian, or independent interpretation of the test performed by another provider, not separately billable, look for these codes, or discussion of management or test interpretation with an outside provider that you are not billing for in your hospital. If someone's billing for that, you can't bill if there's going to be a pathology interp. You can't bill if there's going to be a medical imaging interp. That's already billable, so you can't. Okay, that's just keep it in context. And then your 5, your high levels, 2 of 3 categories. See how you started with 1 of 2, and then you have 1 of 3. Now you have to have at least 2 of the 3. So it's harder to get the high levels, but doing a bunch of tests, it's not so bad. And then your medical decision-making, which will go to the next slide. So 2 out of the 3, any combination of 3 of the following, there's that again, independent, all of that. So those 3 are the same. But in here, you need to have 2 out of the 3. All right, so let's go to the next slide. Terms for medical decision-making, external records, communications or test results from an outside doctor, outside facility. So if I'm reading the ER record right before they went up to the floor, that's not going to count. Outside records. All right. External physician or other qualified healthcare professional, which is right above that. An external physician who is not in the same group practice or is a different specialty or subspecialty. So it could be that you did have a consult from a GI that you're reading, and you could potentially use that when we're getting into the hospital section. Independent historians, here is your descriptor: a parent, a guardian, a surrogate, a spouse, somebody who provides a history in addition to what that patient provides, or a patient who's unable to, maybe they are unconscious or they're not able to speak, something's going on, because we need a confirmatory history. It's necessary. I need to ask, was there loss of consciousness at the scene? Does your mom always act like this? Is this her normal? Is this her baseline? Those types of things. And then independent interpretation of a test for which there's a CPT code and an interp or report is customary. This does not apply when the physician is reporting the service or has previously reported the service for the patient. So you're not going to bill or add this in if it's already being interpreted by someone else. And there's your 3rd column for risk. So rest, gargle, bandages, low risk of mortality for diagnostic testing or treatment. The minimal, then you get to low, might have some over-the-counter drugs. There's more on that purple and white graph, but this is bringing it in. You get into the moderate, you've got prescription drugs, decision for minor surgery, like 10-day or less global, decision for elective major surgery without an identified risk factor. That'd be the 90-day global. A diagnosis or treatment significantly limited by social determinants of health. Pay attention to that one. That one, all those Z codes, if you've got social determinants of health, we've got a potential to be leveling this at a level 4 because of that, because I need to see it in the note and I've got to see the ICD-10 code on the claim as an auditor, but you can absolutely, that would bump you into a moderate risk, because if they can't get their medication, if they don't understand the English language, if they don't have a safe home environment, they're homeless. All of these things affect that. That's absolutely moderate to their risk of outcomes, bad outcomes. And then your high risk, that same drug therapy requiring intensive monitoring for toxicity, or chemo, warfarin, Coumadin, and chemo agents, et cetera. How about decision regarding elective major surgery, and they have risk factors, and they need, if they need emergency surgery, or they have to be placed in the hospital, or if you decide not to resuscitate them or to de-escalate care because of poor prognosis, you're about to put them into hospice, that's high. You've just made a life-changing event for them. I've got a couple practice examples we're going to run through here real quick. So here's an established patient. Now these are offices, but just know that we're going to get their hospital people. Patient has, I'm not going to read everything because I don't care that I don't care what's in the history exam. It just needs to be medically appropriate. All right, there's something up there. We're going to pretend. So here's my assessment: hypertension, controlled on a prescription. I sent the refill prescription order to CVS. And I got my blood pressure and my plan, follow up 3 months. And then they also have neuropathy that's under good control, but I am going to refill their gabapentin and tell them to take that 3 times a day. So that's what I've got. That's driving my medical decision-making. All right, so here's this is a little easier to read than the purple and white one. I'm going to look through here. 2+ stable chronic illnesses. Let's go back. Yep. Hypertension, neuropathy. They're stable and they're controlled. So I have 2 of those. So my medical decision-making, my complexity would be moderate, as long as, I also had the prescription drug management. So I have the 2, I think, the 2 that I need. So I don't need all this, no data, no complexity of anything reviewed. I prescribed a drug and I have 2 chronic conditions that are controlled. I have a 99214. Let's bring this together. 2 stable chronic conditions. Don't care about the amount and/or complexity if don't need it. Because I also did prescription drug management, I've got moderate complexity. Easier, much easier. All right, case 2, new patient. I've got a little bit more here now. I've got a person with upper respiratory infection symptoms. 16-year-old patient, 2-day history of coughing and shortness of breath, no chest pain. I've got my exam. I want to see what's going on with the assessment and the plan. Acute respiratory infection. I prescribed some medication and I had him follow up as needed, PRN. Okay, let's see where we can code this one out. We have 1 acute uncomplicated illness, right? Let's go back and check that. Acute respiratory infection. That's uncomplicated. So my number and complexity of problems is going to be low. Next one, I don't have to do any labs. Pretty excited. Didn't run any anyway, but I don't need them because I ordered prescriptions for this patient. So I have a 99214 because, or 99213, it's a new patient, my bad. All right, 1 acute uncomplicated illness or injury, don't care about labs, and we did prescription drug management. So remember, we have to have 2 or more in the same column. So we drive this over, and we've got 1, 2, we've got low complexity. Okay. The coding by time. In hospital, the time is still, I need to know total time spent with the patient, that part or all of that time was spent counseling and coordinating care for that patient and what it was for, and that over half of it was spent, hold on, back up. Total time, that over half the time was spent counseling and coordinating care for that patient, and what did we counsel and coordinate care for? Got to have all 3. It's pretty easy usually to have the what's going on and the progress notes, but I need to have that total time and that over half was spent doing that counseling and coordinating care. Then I can choose my E&M level based off the time, that rather than the history, exam, and medical decision-making, and it's likely could be higher, especially if the same doc was downstairs in the ER and put them up on the floor. Just depending on our smaller hospitals versus our bigger hospitals, if we don't have a hospitalist, this, that, and the other. But now in the office, it's looking at specific minimum time, not the typical time. It's allowed whether we had counseling or coordination of care dominating the service or not. And we choose time when we're not using medical decision-making. And it's, again, total provider time. But think about this. This has also got to do with your discharge codes right now in the hospital. total time on the same calendar date of service that provider provided to the patient, not other time, not clinical and ancillary staff. And if two providers were both addressing something for a patient, you only count one of those guys per minute, okay, one of those people. So time, provider activities that can be included in the total time, preparing the patient, preparing ahead of time, reviewing the chart ahead of time. This all has to happen on the same calendar date. Obtaining and reviewing a separately obtained history, a medically appropriate exam or history or exam or eval, counseling, education to the patient, to the family, to the caregiver, ordering meds, procedures, referring and communicating with your staff, your time as the doctor, not their time, documenting information in the record, charting. That includes charting. Independently interpreting results could come later in the day. The patient's left. You've already spent 30 minutes, the patient left, and you got your lab results back that same day, or you got a call report back from your MRI, and you're going to communicate that to the patient. You're going to probably document that back in the health record too. And all of that time is going to add up to your total time that you're going to select for your E&M level for that data service. And then care coordination that you might be doing, as long as it's not counting in a 20-minute CCM code for the month. You don't want to double bill. But if you're doing some care coordination, working with home care or whatever you're working with, that can be included too. And when you read the discharge status code for hospital discharge, it certainly says all E&M services done, preparing that patient for discharge. Let me see if I can read that to you, because I think we missed that 99239 a lot. Bear with me, because I want to bring that to your attention. I'm not finding it. Initial nursing facility, no, not critical care, no. Here is my hospital discharge services. Bear with me. I'm going to read this in the CPT guidelines to you because it's very similar. Hospital discharge day management codes are used to report total duration of time spent by a physician for hospital final discharge of a patient. The codes include, as appropriate, final exam of the patient, discussion of the hospital stay, even if the time spent by the physician on that date is not continuous. It also includes instructions for continuing care to all relevant caregivers and preparation of discharge records, prescriptions, and referral forms. That could take way more than 30 minutes. How many of you are billing a 99239 for these? How many of you are getting the doctor to tell you they spent greater than 30 minutes getting that patient out the door? That's lost revenue. I want you to do a little checking on that while you're out and about. In February of 2021, we had some angst, we had some confusion. So CPT came out with this. The following activities are not included in the time counted towards your E&M. Other services that you report separately, travel, teaching that is generally not limited to discussion that's required for this management. So other teaching and ordering and or actual performance and or interpretation of diagnostic tests during a patient encounter, because if you're doing it, you're billing for it anyway. No double dipping. So they kind of tried to clarify that for you. All right, this is your time, your E&M level times right now for your CPTs for office and or outpatient. So specific lists. 99211, there is no specified time because that generally may or may not require the presence of a physician. That's usually what we call a nurse visit. Okay, but there's your time. So this is a nice little cheat sheet for that. This slide talks about E&M utilization patterns. So you see this little bell curve, and this is what I want you to be aware of. If your docs are running a straight line, or your coders, that's a red flag. We need to see a bell. We need to see that the bulk of them, of their codes, are probably going to be hanging out in the middle, the top of the curve. The most of them will be middle of the road. We'll have some shorter ones and we'll have some higher ones, but you'll see this is from the a CMS website. But what I want you to know is we want to see a bell, not a straight line. We don't want the variance. So we want to know that we're reading the documentation. It's going to be less and less with time. If they're strictly spending time, I mean, time is time. It's probably going to start straightening that bell curve out a little bit, but I wanted you to be aware of the bell curve. All right, last slide is all of those links to everything that I was going to show you, the outline, the guidelines, the services guide, the tool. And then this was the final policy of the Medicare physician fee schedule for 2021. Now there's a proposed one out there for 2023, but I didn't put that on here. It's so new, I didn't incorporate it into the slides. And then I'm going to switch to my last slide with the contact information, and I'm going to get into the chat box. So you can find me here, jking@archprocoding.com. We have a website, there's a link to it. If you call the number on the screen, you'll get Julia in our office, but she knows how to find me. And we have a Facebook page too. So be sure to find us on Facebook. When we have exciting things happen in the world of coding, billing in the rural, we do place things out on Facebook. So I'm going to pop open the chat box. Oh, maybe there isn't. I think somebody just asked about, oh, slides will be sent out. Yes. Recording. Yes. It'll land on the page. Sorry, no CEUs. It kind of came up fast. However, I will probably record this and place it up on our website, and there eventually might be something on the Arch Pro Coding website for something like this. We'll be doing a quick, I'll be doing a hospital related one, and I think John Burns or Gary Lucas is going to be doing a office related quick blurb about this on our website too, in the next week or so, just kind of reviewing that 42-page document and giving you a little bit more of a preliminary. But I do know their observation codes are going away. You'll use hospital codes only. So those two things are going to happen. We're going to use time and medical decision making. Those are, I'm sure of those three things. So that's exciting. Any other questions related to the old way and the new way? I can pop back on the slides if you'd like me to.
I don't see anything in chat, but we do still have about 12 minutes. So please feel free to drop your questions into the chat or unmute yourself, and you can ask Jackie personally. We'll hang out for just a couple of minutes, and maybe someone's composing a question. It looks like we do have one. It says, so is ER changing in 2022 or just IP and OBS?
There'll be some guidelines. Hi, Andy. There'll be some guideline changes. I'm literally trying to find them. I printed them out and I can't get my hands on them. Oh, here they are. There is a little bit of guideline changes for the ER, but they will not, you'll not be able to use time in the ER. But they changed some guidelines. Yeah, here's my document. If you go on to CPT E&M effective January 1, 2023 on the AMA website, you don't have to be a member. You can pull this down and start looking at it yourself too. But yeah, lots of changes in the guidelines, because just what I went through with your office, that's going to be what's going to be in the hospital side too. So just mostly guidelines. Let's see. Deletion of hospital OBS, E&M, revision of hospital guidelines because inpatient and OBS are squishing, deletion of consultation codes, revision of some consultation codes. They deleted 99241 and 251. Those low levels were probably differentiated by history or exam. So they're probably dropping those two. They have revised the guidelines for all the ED. They've deleted 99318 for nursing facility. So there's some deletion, deleted some prolonged services codes, revised some guidelines, and established some new prolonged services codes and guidelines. There's a lot, so more to come. Stay tuned. Good question.
Thank you. And so while we hang out for a couple more minutes, I'm dropping a link into the chat. This links back to our website, just because our application portal is open. So if you are in rural hospital and you're interested in applying, you have until the end of the month, and you have some FAQs and stuff you can check out, or contact me if you want more info. And I do see another question. So when one bills LTC through the RHC, are the formats nursing home or RHC?
The code, the CPT codes go by your place of service, but the revenue code goes by your rural health clinic. So that was a loaded question, and I am not so you're going to use the skilled nursing facility CPT codes in that chapter of the E&M, but you'll use the, I can't remember what revenue code, one of the 052 something revenue code that says the place of service was in a nursing home. Does that help, Frederick? You always pick your E&M by where the patient is located. You'll go to that section of the, are they at home? Are they in a SNF, skilled nursing facility, or a swing bed? Are they in the hospital, emergency room, OBS, or inpatient? So go to that section of the book and that'll give you your guidelines. Good. That I hope.
Great. Any other questions? Okay, then I will go ahead and kind of start closing, but please keep typing if you are typing a question. So first, thank you, Jackie.
My pleasure.
Yeah, we love having you. And yes, we will definitely bring you back for the 2023 update.
Okay.
So be looking for that, guys. And like I had mentioned, we will send an email out in the next 24 to 48 hours with the recording link. And then when you click on that, you will have the link to download a copy of the slides. There might also be a survey link that takes about 60 seconds to complete. And then maybe upcoming webinars or something. So be on the lookout for that. Like I mentioned, check the link in the chat if you're interested in our program and being in a hospital. It costs nothing to participate. It is for vulnerable rural hospitals.
That's just me.
Thank you. I appreciate it. And I think that's it. I think we'll go ahead and close since there's nothing else. But if you do think of a question, don't hesitate to send an email to Jackie or to myself, and we will make sure that she sees it. So thank you all for spending your hour with us, and we'll see you next month. Bye, everyone. Thanks again, Jackie.
Thank you.